And I have to introduce now Ladislav Krofta. He's one of the very few obstetricians who know a lot on the pelvic floor. He was also, well, we were also together in the truffle study, and I wasn't aware that he has such an understanding. And now I'm very happy, and we communicated. I'm very grateful that he came again. And I give you the word.
Professor, thank you very much. It's a great honor for me and for my colleague to be here.
We are here not for honors.
We all know these situations daily in the labor ward. We see these situations. This is a normal vaginal delivery. This is a forceps, and the problem, and Carmen mentioned it before, and the problem of modern perinatology is that a lot of obstetricians don't see the patients after the delivery, and here are only few cases of primates of very quite short time after first deliveries. It had not only forceps but also spontaneous vaginal delivery. And the problem is, that we have enough clinical data, we have enough publications, and the first papers was published which used diagnostic tool in year 2003-4-5 was published for Hans-Peter Dietz, and we still don't recognize, and we try to ignore the data. I find this paper, this is quite interesting, that when you look, this paper was published in 1943. This was a European gynecologist in the United States, Howard Gainey, and he published in 1943 a paper. He analyzed patients after first vaginal delivery. He personally performed in these patients, he performed forceps, and he described in this more than 70 years old paper, he was surprised how large group of patients after forceps had, according to his description, severe morphological abnormalities of the musculus levator ani. That's how it works. This cartoon demonstrates the most important structure of the pelvic floor. This is the whole musculus levator ani. You can see, you recognize very nice connection of the puborectalis muscle to the bony pelvis. And fortunately, we have excellent tools. We can use ultrasound, 3D ultrasound, 4D or MRI, and we can recognize excellent the distal parts of musculus levator ani. The most important advantage of 3D ultrasound is cheap. You can perform it anytime, and you can make dynamic examinations. You can tell to the lady, stay relaxed, or make a Valsalva maneuver, or you make a voluntary contractions. You can see the distal part of the puborectalis muscle. You can measure the hiatus, and you know how is the function and how is the morphology. This picture demonstrates a lady after uncomplicated vaginal delivery, and what's very important, you can see the distortion of the shape, and here you can see that the muscle looks strange, and in comparison to the right side, there is a detachment of the muscle from the bony pelvis. And when the lady is pushing the structure, the whole hiatus is enlarged, and when the size is more than 26 square centimeters, this is a very important risk factor for pelvic organ prolapse. But the problem for us, for urogynecologists, is when you have patients, when she is old, when she developed pelvic organ prolapse, and then there is a damage of the muscle, and you perform classic reconstructive procedure, there is a high risk of recurrency. I prepared one excellent paper. It was published last year from Australia, and this is secondary data analysis. There was 403 ladies which was available for follow-up after first delivery. You see 111 had cesarean, so therefore 371 had vaginal delivery. 7 and 14% had vaginal extractive procedure, therefore 8 women had normal vaginal delivery, 4% had oasis. So therefore, this group should be without any problem. Vaginal delivery, no defect of musculus sphincter ani. But look, when we analyze the changes on musculus levator ani, 27 had avulsions. In 31 cases, the defect of musculus sphincter ani was not detected. Therefore, only 193 from the initial number, only 40% was without severe anatomical changes. And when we look also for the hiatus enlargement, only 33% of ladies after first vaginally demonstrate normal pelvic floor. And the most important is, was the age. MRI. According to my experience, the MRI helped us much more better understand the morphological changes of pelvic floor. We can see all the subdivisions, we can see all the parts of the distal part of the musculus levator ani. We can analyze exactly the connective part where the muscle is connected to the bony pelvis. But what's most important, and we cannot see with the ultrasound, we can see also the changes in the thickness. And we should divide, or we should be able to recognize cases where there is a huge change in the connection to the bony pelvis, like here. This is related to the severe, this is a macro trauma, but when you have this type of changes, the muscle is there, but it's very thin. This is related to denervation. This system described John Delancey in year 2003. But what's very important, there is not only muscle, there is only connective tissue, the endopelvic fascia. And in majority cases, when you have severe major levator ani trauma, we can observe also defect in the connective tissue. So this cartoon represents approximately how this can look like. But the most important information which...
You can show this again.
Yeah.
I'm not as quick. Is this not traumatized or is it normal?
Yeah, this is not. When you compare it...
Where's the trauma?
Yeah, when you compare it with this picture, this is normal. This is a normal volume of puborectalis muscle. There is a robust structure and is connected to the pubis. We call this class enthesis. And when you see here is a extremely thinning, but the endopelvic fascia is maybe still normal. Therefore, there is no dorsolateral shift of the muscle. And you can see this should represent this finding. But then there is a disconnection of the muscle of endopelvic fascia. There is a huge change in the anatomy, and these structures we can see very easy with the help of ultrasound. But the most important information which can achieve from MRI, that we can see also the proximal parts of the muscle, the iliocoxygral muscle. And this is not published in the literature. This is our work. This is the work for my colleague from Mikhail Krčmář. We have analyzed 149 ladies after first delivery with symptoms, and we was able to find that the muscle changes are present also not only puborectalis, but also in the level approximately 3 and 4 centimeters higher, and the trauma reached also the iliocoxygral muscle. And with help of the MRI, we can see also the sacrouterine ligaments. So therefore, the most important structure which is responsible for uterus placement. And then we put everything together: the muscle, the endopelvic fascia, and the level 1 sacrospinous ligaments. I think that we can analyze very precisely, and you can create a model which can predict potential pelvic organ problems, symptoms when you have damage immediately after the delivery. And Delancey published in year 2003, when you have vaginal delivery, minimally 20% have major levator ani trauma. When you don't deliver vaginally, the muscle is still there and the muscle don't demonstrate major levator ani trauma. When you look for symptomatic patients in urogyne ambulances, you see that lot of patients which are coming for with pelvic organ problems demonstrate major levator ani trauma. And this is the link between vaginal delivery and symptoms like pelvic organ problems in all group of patients, and the responsible factor is vaginal delivery. We have large experience with this with MRI, and we have created our own model. This is a rectum, this is a musculosphincter ani internus, this is a view from the back. This structure is a puborectalis muscle. I try to rotate now a little bit the picture. Now you can see it from the front. This is an ilococcygeal muscle, this is a musculosphincter ani externus. Here you can see now the subdivisions, the musculus puboanalis, this is a part of the pubovisceral muscle complex.
Wait.
So this is a subdivision of levator ani. We call it the puboanal muscle, and this is the yellow structure. And very important is the connection to the musculus obturatorius internus. You can see it better here, and this is very interesting. This is the puborectalis, this is the ilococcygeal muscle, and here this arcus tendinous musculi levatoris ani, and this is connected to the musculus obturatorius internus. This is the bladder, the green structure. This is the bladder, the green structure is the vagina, and here you can see the comparison to the real life MRI. So, and the connection to the bony pelvis. And symptomatic patients after first delivery, MRI. This is interesting. Puborectalis is there, but the ilococcygeal part, the proximal part, is not in good shape. And look how looks the MRI, the model. You can see it here very nice. The puborectalis is normal, but the ilococcygeal is detached from the musculus obturatorius internus, it is localized dorsally. And when you see other case, this one, there is a severe damage also in the puborectalis muscle, and when you see the 3D model, there is no puborectalis muscle anymore, and everything is dislocated dorsolaterally. So therefore, this lady, she is on high risk of severe pelvic floor, pelvic organ dysfunction symptoms. Here you can compare it with the nullips and with this lady after first vaginal delivery. And when we had this model, we was curious when we simulate some labors. Can I show you this picture? This was published in year 2004. And there are also other models of pelvic floor, but you can see that the fetal head was, in this modeling, was a sphere. In our model, we had precise shape, and we was able to describe very precisely the planes of the bony pelvis. And I had access, and we are a penetrological center, we had more than 5,000 deliveries, and we had one neonate with neurological symptoms, and we have done by then, during the first 24 hours, the MRI scan. And I used the MRI scan to create our first 3D model of the fetal head. And we put everything together with the pelvic floor, and we was able to simulate vaginal delivery with respect to the cardinal movements of labor, according to each station. And we was able to analyze the stretch changes, the stress distribution inside in the musculus levator ani, and we was able to measure that the high pressures are in these places where the musculus levator ani is connected to the bony pelvis. We made also other simulations, we make, in this case, the fetal head was 50th percentile per accident. But these two cases simulate when the fetal head is smaller and when the fetal head is larger. And look what's happened inside in the muscle when the fetal head is large or when the fetal head is small. The yellow and purple colors here are much more stronger. So this is a simulation how fetal head size can have very important negative influence on the stress distribution inside in the musculus levator ani. Then we move to potential obstetric complications, and I'm quite interested on stress distribution in occipital posterior position during delivery. We work a little bit on our model, and we make some animal experiments we took from pigs from levator ani. The pigs had not previous deliveries, samples of musculus levator ani. We make uniaxial tangent biometry, and we put the data in our model, and we have done again the simulation for occiput posterior measurements, and we compare it with the normal physiological vaginal delivery, and we was able to demonstrate when you have persistent occiput posterior position that the stress distribution inside in the muscle are much more higher in comparison to normal when the internal rotation is without any problems. And here you can compare it. Again, this is a normal vaginal delivery with normal cardinal movements of the labor, and here you can compare it. And this is a situation in the persistent occiput posterior position, and the stress distributions here in the occiput are much more pronounced. So this is again a case that we are able to find potential problems which can occur inside of the muscle when we have some specific obstetric cases. The next area of our interest are forceps. We know that the incidence of avulsion injury after vaginal extractive procedure are much more higher and vary between 40 and 70%. And when you use VACs, the incidence of pelvic floor injury should be reduced around 20-25%. And we use our model. We create a 3D model of forceps, and we have inserted inside in our model, and we was able to measure that when you insert each part of the forceps, you increase the stress distribution inside in the muscle minimally by 10 megapascals. And we think this is the explanation why forceps delivery represent very important risk factor for severe levator ani changes. And the last field we work now on it, we try now create new version of fetal head modeling where we can count with fetal head molding. And we don't have the measurements, but we work now on it. We try to be more as realistic. And this is the picture of our institution. We are a public institution, and we are part of Charles University, and thank you for your attention.
So, any questions? Maybe Ximshan Leaf, she comes from Sheffield, she also does modeling. You want to comment?
I've got lots of questions, but I think I don't want to do later. It's very technical questions.
Very,
but yeah, I think it's very fascinating work, and knowing how long it takes to get those computer models to work is not trivial. But I think at the same time, it's a very powerful tool to marry between engineering, technology, and medicine, because there's so many things you can do in a virtual environment that you can't do on the actual patients. And that helps you to understand
Yes.
further what's the complication, what's the best treatment strategy, and how to design certain equipments and techniques. So absolutely agree, and very fascinating work.
Yeah, I think he's one of the only ones in the world I know, a very good clinician obstetrician who is also busy only to make this visible where we should care about. I think 90% of our obstetricians don't even know the names of these muscles and not the lesions which arise whatsoever due to obesity, due to pregnancy, due to... At least I was never taught. I was interested, and because also of the SE business, it's not a business, it's a treatment or a prevention. Anyhow, I think you are doing great work, and I can taste that you really love your patients and you are patient concerned. It's not modeling concern.
A short comment. When I visit the Eurogynae conferences, I hear there we should avoid perform forceps.
Yeah,
I think this is not a good idea. Now, this is a process which is vital for the fetus, and when we move only to VACs, there is a risk that you are not able to finish the delivery with the VACs, and when you don't have knowledge about forceps, you must switch to a very complicated cesarean section. And so therefore we should teach still, we should be able to perform forceps, and we should decide when we should use VACs, and when there is some potential risk, in the situation when there is a long second stage, when there is a persistent occiput posterior position, it's better, according to my experiences, go directly to cesarean instead to wait more and try forceps. Then you can preserve pelvic floor.
Yeah.
But there is a major difference in posterior position. When the trunk is anterior or lateral, then you apply a vacuum and the head rotates, and it is a normal vaginal delivery. When it is posterior, then
this is true. But I like all the Italian groups from Bologna about the peripartum ultrasound. I think this is the right way how we should work with pelvic extractive surgeries.
We are teaching midwives to check the trunk. The head then rotates according to the trunk.
And I think this is a place for midwives.
Yes.
And for example, in Czech Republic, we have a huge problem putting it in the delivery suites with the ultrasound.
I have a question to you all. I mean, prevention. How? Because I mean, we understand that age is important. In the sapiens female usually delivered when she was 16 or 17 years old. Now we are delivering at 37, 38, 49. So age is paramount importance now. But women get pregnant when they are 35. Okay? So how is prevention effective efficacy in under these conditions? I mean, is there any real way to prevent?
I think we have now a huge problem, and this is the age. And the age alone the mother's age represent an important risk. And I do also Eurogynae, so therefore I know how difficult it is when you should fix the stage 2 or 3 prolapse after first delivery when she is 35. How difficult is it? And I think we should look for patients which are on high risk that something of this can occur. And I think the important risk factor is age, the fetal size, fetal head circumference. Head circumference is a very strong predictor of levator avulsion, and we should look how the delivery goes. How is long of the second stage? How long is the second stage, and how is the process of internal rotation? So therefore, we should use our peripartum ultrasound. And the question is, how physio before and during is the predictor? Now I have an excellent specialist in physio, and he is able to teach the ladies to press and make enlargement of levator ani hiatus. He's able to do it, and he used some principal evolution physio. How is it called? Evolution. Kinesiology. He is able really teach the pregnant lady when she press, she is able to enlarge the hiatus, and maybe this
Do
is
you
the
have
way.
any experience with those balloons?
Yeah, but you know,
Yes.
the data from Hans-Peter Dietz don't demonstrate that this is a positive influence. Don't demonstrate.
And
Yeah.
Ladislav, do you have data what Karen said during pregnancy?
Yeah,
What
this
is
yeah.
happening before birth?
Yeah, we have published.
Afterwards, you cannot always differentiate what was there before.
Yeah, we have done a prospective longitudinal study, and patients in the first trimester, when they come to the hospital, the incidence of stress urinary incontinence was between 4 and 5%. So only first trimester, no previous deliveries. Symptoms of stress urinary incontinence, according to the questionnaires, 6%, week 36, 37, 27% increase. After delivery, cesarean sections 14%, vaginal delivery 27, 34, and when the ladies were older, the symptoms was more pronounced 12 months after the surgery. When they was older than 35, goes from 34 till 39. When they was younger than 20, the symptoms goes down.
And in terms of imaging during pregnancy, I mean, did you do also MRIs or modeling for only pregnancy before birth?
We don't look. I do also fetal maternal medicine, so therefore we have a lot of scans of MRIs when there are some congenital anomalies, and I look also for the levator ani. They make for me also the pelvic floor.
And what do you see? Because nobody knows up to now.
Yeah, but we don't have dynamic changes, so therefore we can recognize that the levator ani, there is avulsion, or there is it's not when she had the previous.
And the connective tissue or these ligaments, you know, you have this level 1, 2, 3.
Yeah.
According to cadaver
You can see it excellently on the MRIs. You can see it excellent, and I show it here in my presentation. The
You can
cartoons.
see what excellent.
You can see levator at the level.
Yes, I understand,
L.
but due to pregnancy, do you see more prolapse before birth
No,
already?
I don't have experience in this.
Yeah, that is my question.
Yes.
Because this would answer the question whether it is at all worthwhile trying to stop over distension of the connective tissue and the ligament.
Yeah, but we know that pregnancy by itself is an important risk factor for pelvic organ dysfunction, especially stress urinary incontinence. and this year, you know the study group from Sweden, the SWEPOT, and they published symptoms of stress urinary incontinence 20 years after first delivery, only first delivery, and they demonstrate that also when the ladies has cesarean section, only one cesarean, they have more stress urinary incontinence in comparison to nullips. So therefore, only the pregnancy is a risk factor. And cesarean section don't prevent all cases of stress urinary incontinence.
Okay.
Of course, it doesn't prevent all cases, but it prevents a high proportion. And
Yeah.
if I look at the German society, less than 1.8% of women have 4 and more kids.
Yeah.
So more than 98% of the German population, of the German women, have only 1, 2, or 3 kids.
Yeah.
So if I listen to the last 2 talks, I really wonder why we are not more. I know it's very offensive what I say, but especially among obstetricians, I love to be an obstetrician. But for me, the conclusion out of the talks would be we not only need to offer C-section to any woman, we need to recommend C-section to any woman,
Yeah.
if we have like 40%, and I mean, we have no predictors, no true predictors. Of course, we have risk factors, we have associations, we all know, but we have no true predictors. Even a completely healthy, sportive young woman, 22 years of age, can have a severe complication, and you cannot say what happens. So the only conclusion, or the only thing where you can really be sure that this outcome will not occur, is to do a primary C-section, that's it.
Yeah,
And
this
you
is,
have more autism, you have less breastfeeding,
you need
you
to-
have also other outcomes. I mean, this
But no,
that
but-
is why I like
Ine.
that he does
Yeah.
this lecture.
Yeah.
He looks at
You know,
the whole
there is-
picture. The whole picture.
But this is a very good and reasonable point.
Yeah.
But
Yeah.
this is likely to be an issue of trade-offs. The vaginal delivery versus cesarean section in the long term is likely to be finally an issue of trade-offs, because you will get benefits with one thing and you will get disadvantages, and the trade-offs will be different. And my challenge as a neonatologist to my obstetric colleagues is that please tell me if there is a very long-term follow-up study comparing both mother and infant
Yeah.
outcomes in relation to vaginal delivery or cesarean section. That's point one. And point two is, some years ago, not so long ago, a few years ago, one of my research fellows attempted to understand whether or not our obstetric colleagues would be willing to randomize women, offer randomization to women who had no medical indication for cesarean section, but just choice, so it was pure, to offer them randomization to vaginal delivery or cesarean section. And our obstetric colleagues pretty much
Yeah.
said this.
Yeah.
So it's a very good discussion to have here, but until we know the long-term consequences for both types of delivery, and until elective cesarean section, or never mind elective, but cesarean section without medical indication is put to the test, we will continue to...
Yeah, but you
Have no
cannot, I
answer.
mean, this is a multivariate model. You have the age of the mother, you have the weight of the baby, you have the position of the baby, you have whether the mother wants to decide for 10 babies more or not. I mean, you cannot just, so simplify it for one outcome or for one maneuver. But at least what we can learn from this lecture is when we have an older woman who only wants that one child and she has occiput posterior, we should not go on and on,
Let me say just
Yes.
one comment. We have those studies, very long-term studies already, because they use unique information from Scandinavian national registers, because they are created from 1970s. So those data are from ladies about 10,000, 15,000 of ladies. And those data are extremely robust, and they say it absolutely clearly. If you compare ladies with an elective cesarean section to climax with vaginal delivery, so the cutting edge of age is 30. If you deliver your first baby vaginally after 30 years of age, you have 9 more higher probability you have stress urinary incontinence, and 11 more high probability to have POP.
In terms of that one outcome, and that again supports the political model, and then we are back to the beginning, that the East German communistic non-commercially driven system supported young mothers. Yeah.